Good evening and welcome. Thank you for joining our fourth Enclave webinar on managing patients with lung cancer through the COVID-19 pandemic, What to Know. I'm your moderator this evening, Gina Columbus. I'm the editorial director for Enclave, and I'm thrilled to be with all of you again tonight. The mission of this webinar is to provide our listeners with a free-form discussion on how you and your colleagues are managing your patients with lung cancer during the COVID-19 pandemic. As we have done in the last few weeks, we will cover a list of topics that each faculty member will go into greater detail on and share their insights from the front lines. As you can see from the slide, tonight we will be gaining outside perspectives on some best practices during COVID-19 from a very special guest tonight, who will also be highlighting some adaptions with immunotherapy, focusing on pneumonitis as well. We will also discuss the risk of venous thromboembolism in COVID-19 positive patients, and our panel will highlight some case-based discussions surrounding imaging and TKI discontinuation. So we do have a few housekeeping notes. If you're listening to the webinar, we encourage you to submit any questions you have, and we will try to answer as many of them as we can during the Q&A portion of this webinar. We're actually going to be kicking off the Q&A section earlier tonight than usual to try and fit in as many questions as possible. Also, to expand your video player to full screen, click on the icon on the lower right of the player, hit escape on your keyboard to revert back to the smaller player. So we have a very distinguished panel of experts on tonight's presentation, and I will ask each of them to introduce themselves and give their title and affiliation. Dr. Agarwal?
Hi, everyone. I'm Charu Agarwal. I'm the Leslie Heisler Assistant Professor of Medicine at the University of Pennsylvania's Abramson Cancer Center. I specialize in thoracic oncology. It's such a pleasure to be here.
Thank you. Dr. West?
Hi, I'm Dr. Jack West. I'm an associate clinical professor in medical oncology at the City of Hope Cancer Center in the Los Angeles area. I also help direct the growing remote consult service there, and my focus is on thoracic oncology as well. Happy to be here again.
Thank you. Dr. Pinnell?
Hi, I'm Nate Pinnell. I am an associate professor of medicine and director of the lung cancer and medical oncology program at the Cleveland Clinic, Felsic Cancer Institute, and glad to be back this week.
Thank you. Dr. Liu?
Hi, Stephen Liu. I'm an associate professor and director of thoracic oncology and developmental therapeutics at Georgetown University in Washington, D.C.
Thank you. And last but not least, Dr. Naidoo.
Hi, I'm Jarushka Naidoo. I'm an assistant professor of oncology, specializing in thoracic oncology and immunotherapy at Johns Hopkins University, and I co-direct the Johns Hopkins University Immune-Related Multidisciplinary Toxicity Team.
Thank you so much, everyone. And Dr. Naidoo, we're so happy to have you here tonight to share some of your experiences and the research that you've been working on with COVID-19. So thank you so much. As I mentioned earlier, this is the fourth webinar in a planned series, so anything that's not covered during this discussion can certainly be raised in our subsequent webcasts. We have a great deal of material to cover tonight, so let's dive in. To start us off, I'm going to provide just some quick numbers on the current state of COVID-19. Currently, as of today, the number of global confirmed COVID-19 cases are more than 1.9 million, with more than 123,000 deaths. The United States has 605,390 confirmed cases, with 24,582 deaths. Meanwhile, we're all continuing to observe the social distancing guidelines we've been instilled upon us for several weeks now, but this is much more challenging to follow for our patients who have serious medical conditions that do require urgent attention. Over the last few weeks, we've discussed how COVID-19 has truly impacted everything from how our experts would manage lung cancer in their patients to preventive measures that they're taking in practice. And tonight, we're going to be hitting on some other impactful topics in this space. With that, I would like to turn it toward our discussion with Dr. Naidoo. So I know our panel has several questions for you, but would you care to first highlight some of the experiences that you have been having here at Johns Hopkins Medicine and some of the research that you have been working on?
Sure, and thanks to everybody for the opportunity to take part and to share what we at Hopkins have been doing in this space. So I think from an oncology perspective, Hopkins has made several adaptations to the way we deliver cancer care across the enterprise. I think this can be separated into sort of three main areas. Firstly, the inpatient service. Secondly, ambulatory care, which involves adaptations to how we deliver cancer care in the outpatient setting, as well as in the urgent care setting, which is a service that many of our cancer centers provide, where patients with cancers may be able to access emergent services, but without necessarily needing to go to the emergency room. And then third, purely from an outpatient setting. So from an inpatient setting, I think most of us recognize or have been preparing for a potential surge in COVID-19 cases. And certainly in Maryland, we have seen a steady increase in cases. At present, our last census, an email from today, we receive emails usually twice a day with the updated numbers. So Johns Hopkins Medicine across the enterprise, which includes sort of 5 main centers, has around 1,200 cases, both in the inpatient and outpatient setting, that they are currently managing, and in and of the region of between 200 to 300 inpatients, a small percentage of them being within the cancer center. From an inpatient service setting in oncology, we've instituted a first and second level backup attendings for the delivery of care of the inpatients if one of the attending physicians or the team were to be exposed or to become unwell from COVID-19. In addition to that, as many of you know, Hopkins has a number of sites. So Johns Hopkins downtown is sort of serving as the main hub for COVID-related care. However, each of the sites, Bayview, Sibley, Suburban, Howard County, all of these sites have dedicated COVID-19 wards or areas of care, and COVID-19 external testing sites or tents where patients may be able to have an expedited test for COVID-19 in the outpatient setting. How we have rationalized that inpatient care is that the more acute or severe cases are sort of centralized on the Johns Hopkins main or East Baltimore campus, and this is where many of the clinical trials for severe COVID-19 cases are being opened, and patients would be then transferred to Johns Hopkins East Baltimore if they were felt to be a suitable case for one of those clinical trials. From an ambulatory care setting, I think what we've done that is fairly unique. I haven't heard other centers do this, but I'd be interested to hear from the panelists if something like this has also been done, is we have quite a well-established urgent care service for oncology patients who appear to have acute oncologic issues in order for them to be seen by a mid-level provider, and usually those providers then have access to quicker diagnostic imaging and other workup to sort of prevent those patients from having to go to the emergency room and taking the pressure off the emergency room. So in light of the COVID-19 crisis, Hopkins has actually built its own dedicated biomode unit. So this includes a set of 12 negative pressure rooms in the ambulatory or urgent care setting for patients who are either a confirmed or suspected case of COVID-19, who may also have other concurrent oncologic issues, or be a concern for an oncologic emergency, such as, say, febrile neutropenia or immune-related pneumonitis, as we're going to discuss further, because these patients may not technically, they would need oncology directed care, or the providers in the emergency room may not be particularly familiar with some of the issues that these patients may have. From an outpatient setting, there are some other sort of unique adaptations that I think have been useful. So not only do we have this sort of drive-by ambulatory testing for COVID-19, but in this sort of new era where we're trying to adapt to give patients less and less opportunity to be exposed, or even providers less and less opportunity to be potentially exposed. We're also trying to adapt other oncology treatments to be given in this manner, such as subcutaneous or intramuscular injections, giving GCSF this way, to sort of prevent a patient having to actually come in for a dedicated oncology visit. So I think that is potentially useful. And then lastly, from an outpatient setting, we are, within the thoracic division, we are sort of adapting our clinical practice to try to minimize the potential for exposure to both patients and providers. So where we each would have necessarily had a clinic day, now we're doing a half a week each and seeing each other's patients. So having a full day where anybody who needs to be seen in person would be seen by a consistent provider, and then they would only be on again in about 4 weeks, so that if a period of self-isolation was required, that this will hopefully maintain the workforce and make sure that both patients and providers have minimal opportunity for exposure. And then the last thing I guess I want to mention is the testing capacity. So I think testing capacity has sort of been an issue across many different institutions. And I'm sure, the other panelists and others who are on the phone will know that actually the lab researchers have come to our rescue in some of these situations. So at Hopkins, Liz Jaffe and other lab researchers have offered up their reagents and adapted their laboratories and converted them into COVID manufacturing test kits. And now as many as 50,000 test kits have been manufactured within good old-fashioned scientific labs that were used for scientific purposes, but now are being used for COVID-related purposes. And this has allowed us to be able to scale up the testing capacity. As many of you know, the turnaround time for these tests can be very different. So Hopkins has tried to rationalize this by using sort of a rapid turnaround test where a result can be obtained in as little as 45 minutes for patients who go to the ED, and actually patients who are going to labor and delivery. So patients who are due to deliver a baby, to have the mother and the baby separated and the mother tested. If the mother is COVID negative, then to have that separation occur. And then the interim test, which has a turnaround time of less than 24 hours, is being prioritized for cancer patients that are either admitted to the inpatient setting where there is a concern for COVID-19, or patients with cancers who are being treated in the urgent care, so that we may be able to triage these patients appropriately and give them the care that is appropriate for their condition.
Jarushka, that's a fantastic overview of what you're doing at Hopkins. We have been able to do many of the same things at Penn, including the availability of rapid turnaround tests for select patients, as well as expedited testing for oncology patients. But we are not currently using universal testing for all of our solid tumor patients. Certainly those patients that are undergoing, an allogeneic or an autologous bone marrow transplant, or are coming in for, some other myelosuppressive or myeloablative chemotherapy regimens, are getting testing. How are you managing patients with solid tumors at Hopkins? Is testing only for patients that have symptoms and or radiographic findings, or are you testing anyone prior to starting chemotherapy?
Yes, so I think the decision to test is still very similar to the model that you describe. So we have a standard screening algorithm where patients, and that algorithm again has been updated every couple of hours, depending on what symptoms. In the beginning, I think it was relatively basic, but it seems to have become more refined over time. So for oncology patients, it really is patients who are symptomatic. We are not screening asymptomatic patients, except for the patients who are slated to come in for a bone marrow transplant, or separate to oncology, a solid organ transplant. So those appear to be the only ones that we are currently screening. Controversially, those with radiographic findings only that are asymptomatic do not currently fit under that algorithm. So I think those are currently discussed and managed on a case-by-case basis.
So, Jarushka, I wanted to ask as well, you spend a large amount of time thinking about managing immune-mediated adverse events, and there's a lot of wariness, trepidation about even starting immunotherapy in patients, regardless. I'm talking really about the patients who don't have a coronavirus positive, but are asymptomatic and presumed negative. Are there any changes? What are the kind of institutional policies, if any, or is it largely ad hoc about people's threshold for initiating immunotherapy, whether single agent or perhaps particularly patients who might be getting a nivo-ipi kind of combination, and also if you can speak to what happens if a patient is on immunotherapy and has a rather non-specific increased cough, little fever, things that we know happen, and does the world stop turning, and what happens at that point in somebody who has been on immunotherapy?
Yeah, I think those are great questions, and definitely questions that I think are pervasive in the minds of many of us as thoracic oncologists. I think, the main take-home message is, even though we are in the midst of a pandemic, lung cancer doesn't take a holiday, and we still have to treat our patients appropriately, but taking this extra consideration in our minds. And I think if I was going to give someone immunotherapy single agent or chemoimmunotherapy, that doesn't change. There are, those patients still deserve that treatment, and that may be the most appropriate treatment, but it's sort of an adaptation as to what method by which we can deliver those treatments is safest for both the patient and those who are administering the treatment. So I don't think our choices of treatment have necessarily changed, but our ways of delivering them have. I think in terms of initiation of treatment, that really hasn't changed very much at all. We are still giving patients single-agent immunotherapy or the combination where it is deemed appropriate. I think where there are changes are potentially in the choice of treatment regimens that minimize visits. For example, in patients with metastatic squamous non-small cell lung cancer, where we could have given carbotaxol pembrolizumab or nab-paclitaxel pembrolizumab, now we may go for Taxol, where we know that this is just a Q3 weekly regimen, and this has made the difference in that choice. Whereas before, it may have been more of a nuanced discussion with regard to the side effect profile. Now we may have more of a preference. I think in those patients who can get to durvalumab, if there is a way to give it Q4 weekly, if there is a way to give immunotherapy, other immunotherapies Q6 or Q4, we will try to do that. We are certainly getting pushback from those elements of the clinic with regard to reimbursement, a concern. But I think where we can give it, we are certainly trying. The last thing I think in terms of immunotherapy adaptation is those patients who are already established on immunotherapy. So those who have already received, more than a year of immunotherapy, we're having serious discussions about whether it makes sense to defer a couple of doses. Certainly those who've had 2 years, whether it is the right time now to stop. And really, different patients have different thresholds, I think, as to what they feel most comfortable with. But when you're weighing up the risk of exposure to a potentially fatal virus, the discussion is very different.
Sure.
And Jarushka, one of the things that you're very known for is treating the things like pneumonitis related to immune-related side effects. So now when you see someone, or someone at Hopkins sees someone with cough and radiographic changes, that look like they could be immune-related pneumonitis, but in the COVID, you see something practically identical. How is Hopkins managing differentiating those two?
I think the same as many of you, with difficulty and with a phone call to Jarushka. So we sort of recognized in the beginning that this was going to be an issue because, as many of you have, the clinical presentation, the radiographic presentation is very similar. And I think the principles of immune-related toxicity are the same, that, we want to rule out any obvious competing diagnoses, of which infection is one. And now we have a new infection that is important for us to rule out in all of these patients. So I think how we've approached this is to try and develop. So we brought together our immune-related toxicity team. I think we're very fortunate, regularly discusses these issues. So bringing those people together and having a discussion within days of this becoming obvious, to be a very serious issue was something we prioritized. So we basically adapted an institutional algorithm, which is very similar to the published NCCN, ASCO, SITC algorithms, and sort of inserted where we thought COVID-19 testing was a priority and identified what some of the main issues were or how they may be different to the published algorithms. So I think some of the main issues are, first of all, I would always have been a proponent of trying to do a bronchoscopy to truly rule out who has malignant lung progression or infection. I know others definitely don't prefer this because it's an invasive test and bronchoscopy obviously isn't pleasant. But I think in the COVID era, where this is an aerosolizing procedure and may carry its own risks, I have definitely scaled back on that and sort of said, and as a group, we have said we are going to pretty much universally try to avoid bronchoscopy in patients with what we think is symptomatic pneumonitis because of the risk of aerosolization and the need to potentially conserve PPE, and really make this only on a case-by-case discussion basis. So I think that's one of the main changes. The second is the use of steroids. So as many of us know, for nearly all immune-related adverse events, corticosteroids are the backbone of therapy and can cause near complete resolution or at least improvement of those immune-related adverse events. And in pneumonitis, that's upwards of 80% of patients usually will have their pneumonitis improve with corticosteroids. So we obviously don't want to withhold corticosteroids in those patients in which we think pneumonitis is the most likely diagnosis. But equally, there are some concerning data showing that virally driven ARDS syndromes may not benefit from steroids and that these treatments may reduce viral clearance. But I think really when you delve deeply into the data, and that's what we sort of did in our SOP, there's data on both sides of the coin there, where corticosteroids are used as sort of a supportive therapy and may actually help patients in some way. And definitely there is data based on SARS and MERS that doesn't necessarily support the harm of corticosteroids. So in an attempt to sort of bring all of this information together, after the initial outbreak in Wuhan, the Chinese Thoracic Society came together and issued some guidelines on corticosteroids. And basically the guideline says that corticosteroids for a short duration and of a moderate dose, which is the same dose as we would give for immune-related adverse events, of 7 days was not deemed to be harmful. So I think really a short trial of steroids in a patient where we are wondering if they have pneumonitis doesn't appear to be immediately harmful. So I think that that's useful information to tailor our approach. So in our SOP, we advise that in patients with grade 2 pneumonitis, where we could potentially wait 24 hours to get a COVID-19 test, we would do the COVID-19 test, we would wait for that 24 hours, and if it comes back negative, we give our steroids and treat as checkpoint inhibitor pneumonitis as we normally would. In the grade 3 cases where many of us may feel more nervous to wait to give steroids, we would give steroids empirically, do the COVID-19 test concurrently, and if the COVID-19 test comes back positive, then work with our infectious diseases colleagues to potentially withdraw the corticosteroids, again, on a case-by-case basis.
Jarushka, a big part of your practice is clinical research, and all of us are big advocates for the role clinical research plays in our patients with lung cancer, but we've had to scale back in some way or another. Can you tell us how Hopkins has adjusted their clinical research program and how that's impacting your practice?
Yeah, so to be fair to the clinical research enterprise, they were on this immediately, and what we were charged with doing was really looking through our clinical trial portfolio and any other clinical research activities and classifying them on a tiered basis, where tier 1 was deemed to be essential clinical research, where patients were being offered a treatment in the form of a clinical trial that really would not replace any other treatment option for that patient, where really they wouldn't have any other option besides the clinical trial. And those clinical trials were prioritized to be kept open. Whereas other clinical trials where really it was the option being offered was a variation on currently accepted standard of care, or could be argued to be as such, would be temporarily closed or held. And in those clinical research projects that really were for the greater good or greater benefit of future science or scientific questions like purely translational studies, obtaining blood samples and other related samples, would most definitely be put on hold because of the risk of study personnel interacting, exchanging these samples and potentially increasing exposure risk. So as a result, our clinical research throughput and the trials that we have kept open have been really at a minimum. And I can count on two hands as to how many trials are actually actively open and accruing. So I think this obviously has affected many academic centers, not just ours, and will have a long-term effect on the progress of our field.
Great, thank you so much. Now, the risk of venous thromboembolism in patients who have COVID-19 has also been an area of concern in a lot of research recently. You all maybe discuss this risk factor and what to look for.
So I don't mind kicking things off because I know that I had brought this to the attention of the group. Well, everybody knows about it already, but I had suggested it. So I think this crossed my desk again in the context of the pneumonitis SOP. Another reason for our patients to be short of breath, of course, is pulmonary embolism. So we know that unfortunately all of our patients with cancers, the cancer itself and often many of the systemic therapies we give, including cytotoxic chemotherapy, are associated with a hypercoagulable state. So our patients are unfortunately often patients who develop venous thromboembolism in the form of DVTs or pulmonary emboli. Emerging data from China and other institutions have shown in autopsy studies that patients may develop pulmonary microthrombi that may be implicit in the respiratory failure that occurs in patients who develop severe COVID-19. And then subsequent studies have shown that patients who were not given DVT prophylaxis or standard thromboprophylaxis may have developed these venous thromboembolism events with a greater clinical severity. I think many of these studies thus far are case reports and case series of local experience. Many of them actually, the patients did not actually receive standard thromboembolic prophylaxis, and therefore our ability to interpret whether there is actually a greater risk of venous thromboembolism from COVID-19 itself is very difficult to elucidate. We also know that really all patients with a critical illness are at a higher risk for venous thromboembolism because of their immobility and because in critical illness, many acute phase reactants are upregulated, elevated D-dimers, elevated fibrinogen. These are things that are sort of universal in a critical illness in many cases. So I think these are important data. It's important for us to know that pulmonary embolism and DVTs are on our differential. We should keep it in our minds. But I think it is unclear as to whether this is a COVID-specific phenomenon or just a factor related to critical illness, and one in which our cancer patients are already predisposed.
I agree. I think that's a critical question that we're debating online and wherever we get the chance. Is just, yes, we are far more aware increasingly of thrombotic complications and whether it is overtly clinical clotted lines or seen in autopsy series, but then trying to clarify if this is really a COVID-19 specific finding or just a manifestation that we have or should have recognized as being very common in ARDS and as you say, in acute illness and SIRS. So I think there's certainly, I think it's good to be looking at the questions, checking D-dimers, and trying to clarify this, but I think it's a mistake to go too far down the mindset that this is a unique situation that merits ad hoc management, totally different from what we would otherwise be doing for these patients.
I mean, it seems higher, right? I mean, we live in a different world now, and anecdotal medicine is transmitted through social media and electronic means so quickly now. But when you're seeing pictures of cutaneous manifestation of thromboses, when you're seeing series reporting 25-30% of patients with VTE, it seems higher. And I agree that we shouldn't, that's not the same as saying low dose or full dose anticoagulation is a benefit. That may be of great harm, but I think standard VTE prophylaxis, we just need to remember to employ that, and it needs to be studied. I think
I think many of us are actually not seeing patients on the inpatient side as often as we do on the outpatient side, or get a call that I'm really short of breath. So I do think that for these patients, especially with lung cancer, who present with these symptoms, we must act expeditiously and get radiographic imaging as soon as we can, not just to look for, pneumonitis type symptoms or findings on the scan, but perhaps also looking for VTE now.
Yeah, I think there's enough evidence anecdotally and through these series to certainly have a high degree of suspicion to watch out for this. I think one of the messages that I get from this is these serious issues are in many cases being discussed in scenarios like this, where we just have people discussing them on webinars. We have small case series being published, sometimes not even in peer-reviewed publications. We really need more information about what is going on with cancer patients who are infected with COVID, both in the outpatient setting and on the inpatient setting. And so I wanted to also highlight that there are some major national and international efforts going on to try to learn more about what's going on with cancer patients and COVID infection. There are large registries that are currently ongoing. There is an effort led by Vanderbilt and University of Washington called the COVID-19 and Cancer Consortium, which is it has a website, ccc19.org, which has a non-PHI registry that practitioners can enter data from de-identified patients right now, trying to gather information. And I think at this point there's something like 90 institutions that are participating with that and growing. ASCO and ASH both have national registries that are currently rolling out, and they may already be collecting information. I also saw that the NCI is putting out grant funding to develop registries. And so hopefully all of these organizations are working together. But my guess is that these are going to move really fast. I know we're participating in one of these registries at the Cleveland Clinic. And within hopefully a period of weeks, we may have a little bit more significant information than what we've got now.
Thank you. This is really wonderful insight. So there are some cases that we're here to discuss tonight too, right? So shall we get into those?
Yeah.
Okay. Do we have this slide?
Okay, so this is one that I think I would love to hear Jarushka's input on this. So this is a patient of mine that was a 76-year-old patient on single agent pembrolizumab. The image on the left is, there's prior radiation in the left lung, and that's all sort of chronic changes. Patient was doing very well. And then on the next set of imaging in April, you can go back. That's a different one. You can see that on the right side there. So I was actually called by the radiologist. They've started calling people whenever they see anything that looks like it might be new ground glass, mixed solid ground glass infiltrates that could be indicative of viral bronchiolitis or COVID. So I got a call from this about this patient scan that it had these new infiltrates suspicious for COVID. There was no evidence of any disease progression. The patient had no symptoms whatsoever related to anything, so at this point, our guidelines were completely unhelpful as to what to do with this patient. Did not qualify for our testing guideline, actually, since there were no symptoms or clear contacts. So we elected to just basically call every other day and check in and make sure the patient was doing okay. And in retrospect, about 7 to 10 days later, the patient noted that they actually had a cough that they were attributing to their baseline cough that maybe actually was worse and now has actually gotten better. And they never really got very ill with that. But I'm very curious about how you guys manage something like this.
And Nate, before we move on, was there a new oxygen requirement? Was there anything different, cough or any new symptoms?
The patient had a baseline cough that was chronic and was subjectively no worse than usual. Although, again, when we followed up with regular calls over time, the patient noted that the cough actually had improved. So maybe actually was worse at the time, but didn't pick up on that.
I think this is a great case illustrating sort of how we would manage or how we would approach grade 1 pneumonitis. So interestingly, I just wanted to ask Nate, did you hold immunotherapy that day or did you proceed with the treatment?
So I actually had looked at the scan and my initial thought was that this might be grade 1 pneumonitis, and after having talked to the patient and discovered that they were completely asymptomatic, we went ahead and treated with pembrolizumab. And then I got the call from the radiologist about it potentially. So I was like, oh gosh, maybe I shouldn't have done that. Although, the half-life of these drugs is so long that I'm not sure it would have made much difference whether I continued or not. But
yeah, so I think so. What Nate did is basically follow the exact NCCN guideline for grade 1 pneumonitis. So in these patients, they're asymptomatic or there is no change from their baseline respiratory status, and they develop some new radiographic findings. And the recommendation is to either withhold or to tentatively proceed with treatment and monitor closely. So I think that there is an argument to proceed with that. Even in light of the COVID-19 crisis. I think an alternative approach, and this is sort of something that we have thought about and are sort of instituting at Hopkins from our algorithm, is in these patients, it's unclear and I think controversial right now as to whether we should test these patients for COVID-19 or not. I think that recommendation is probably going to be region specific. If you're in an area where there isn't a lot of this, or patients don't have sick contacts, or the risk isn't deemed to be specifically high, there may not be a need. If you're in the middle of New York in a crowded area, that might be a different recommendation. So I think judicious use of the test where it is available or where it is possible may be appropriate. And I think, proceeding with the treatment would be in accordance with what is published already, but holding treatment as well, I think wouldn't be wrong, particularly because, as Nate says, we know that the half-life of these drugs is fairly long, and repeated dosing may not necessarily put fuel on the fire. So I think the only thing I may have done differently is I may have held the dose, but I think that would be how I would probably manage grade 1 pneumonitis even when there isn't COVID-19 around.
I think the decision to test is region specific. But I think we also agree that if all of us had access to unlimited tests and it wasn't a logistic problem, that we would test at the drop of a hat, maybe universal testing even, because in a situation like this, if you have a rapid test, then you just test and then you can base your decision right away on the results.
Right.
And that was the stark contrast that we witnessed last week when Dr. Mark was on the program, and he talked about, widespread and easy availability of all of these tests and how they're testing 3 times a day. I mean, batches of tests being run 3 times a day. So I think in that perfect scenario, this would be the kind of patient who would get tested. You wait for the test to come back and then treat accordingly.
And I would say that this was 2 weeks ago, which is basically a year ago in COVID time. So we've internally discussed this, and now this patient would absolutely get a test. We have actually a pretty nice setup now to get rapid in-clinic testing done for our patients. They can basically get it while they're waiting. And then, but I did want to point this. So if you go to the next slide, this is not unique to us. And there was a publication just in the Journal of Thoracic Oncology this last week, a case report of a patient getting chest radiotherapy, and just showing that over the course of 3 days of treatment, emerging ground glass nodules, and the patient ended up apparently becoming very symptomatic from COVID and being admitted to the hospital. Just to illustrate that this is something that's going to be happening to everyone quite a lot, and this is not going to go away. We're going to actually now have to work this into our regular algorithms, maybe for a while, indefinitely.
I think the issue of thoracic radiation, as well as the potential lymphopenia, that we know that thoracic radiation can cause this. And then if that is something that is also something we need to disentangle from COVID, that's going to be even more challenging.
Okay, well, we want to make sure that we leave time for questions. So thank you so much for the faculty for participating tonight and sharing this insight with one another and with our listeners. And thank you to Dr. Naidoo for being available to discuss all this with us. We really appreciate it. So right now we're going to open up the question and answer portion of this webinar. So if you go to the Ask Question and Answer box on the right corner of your screen, you can type your question directly in the box and then hit, directly in the space that is in the box, and then hit Submit. So we do have some questions already lined up. So if the panel is ready, I will begin. So one of our first questions that we have here is, do you have experience with the use of tocilizumab in patients receiving checkpoint inhibitors?
So I can take that. So I personally have not given tocilizumab for an immune-related adverse event yet. I have had experience of giving it for cytokine release syndrome in the context of CAR T cell therapy, where of course it has demonstrated benefit. And I think that is obviously very well informed based on studies in which IL-6 upregulation was found to be the mechanism underlying the development of that toxicity. There is a published study looking at giving tocilizumab in patients with immune-related adverse events. It's a single institution clinical experience, but we do not as yet have any data beyond that one publication for immune-related adverse events.
And there is emerging data to use tocilizumab in the setting of cytokine release syndrome in patients that have documented COVID or that have serious respiratory illness or ARDS with COVID. However, I personally don't have experience, and these are again anecdotal reports. And I don't think we can at this point generalize our use beyond how we use this for CAR T cell based approaches.
I would say as well that there is sorry, Steve. There's we're all clinical trialists on this call, so we're all going to be very supportive of clinical trial efforts to actually answer this question. So there are a number of clinical trials that are accruing, investigating the role of an anti-IL-6 agent for severe COVID, and not just tocilizumab, other IL-6 agents such as sarilumab. So I think that we would anxiously await those data and allow them to guide our practice.
Yeah, I think that one of the TOSI studies accrued in unbelievably quickly, just sort of showing the need and the rapidity with which these trials can be done. We've used TOSI for cytokine release as well. But just to remind everyone of reporting bias, when you see these success stories, these miraculous stories of patients who receive TOSI and are off the ventilator, have dramatic results, remember that we don't really sound off so much about cases where it doesn't work. We've had several cases where we haven't seen those dramatic results, and those don't make their way to the public eye, and that's why we really need to see the data to show that it is providing some benefit.
Well, and again, Stephen, you made the point earlier in the hour that we are in a time when one or two positive reports can reverberate through social media over and over again and have a disproportionate effect. It's not the same thing as a prospective trial. And so we really need to temper our enthusiasm and still look at these things carefully and not just rely on anecdotal reports to get irrationally exuberant and guide our therapies beyond where the data really should lead us.
Great. All right. Next question. How are you evaluating and treating patients who were, 1, scheduled for a tissue biopsy, or 2, may be progressing but cannot receive a CT at this time?
So we are able to do CT scans. While initially my patients had concerns about doing a CT scan at Georgetown in a scanner that is connected to the hospital, I actually feel very safe with our CT scans. I know that when we have a positive patient or suspected patient, that the decontamination process is very thorough, that it takes 1 hour between scans, that they are taking those extra safeguards. And so we have the access to scans. I think what we're doing to try to minimize risk is reducing scan frequency when it's not so critical, eliminating sort of optional or borderline calls. But if a scan is needed to look for progression, then we won't hesitate to do it.
And I would say for tissue biopsy, we are discussing all these cases that are multidisciplinary tumor boards, and we are avoiding bronchoscopies as our way of obtaining tissue biopsies as much as we can for reasons that Jarushka raised earlier. And we are still getting tissue biopsies for new diagnoses. CT-guided biopsies are our preferred approach, and our interventional radiologists have been very accommodating in triaging these patients and also selecting the best site for these kinds of biopsies. And then again, there are instances where we are only able to get FNAs. And we are doing the best we can to get these diagnoses quickly. I will say that for patients with stage 3 disease, earlier, pre-COVID, we used to really try and get adequate mediastinal staging with EBUS and bronchoscopy, and make sure that we know exactly what level of nodal involvement there is. We've relaxed those criteria in these times, and we are again discussing these cases in our multidisciplinary tumor boards, but we are deferring really histologic sampling of these lymph nodes if otherwise they appear positive on PET, etc.
And I think it's a lot like, Jarushka noted that people who should be normally getting immunotherapy or chemoimmunotherapy, where it's the clear standard, they're getting that. And I think that makes sense. It's everything we're talking about. I mean, if you have somebody who has disease that needs a biopsy, they get a biopsy. We are proceeding with that. It's the patients who have a solitary, ground glass opacity that if you squint at it may have a solid component now, or it might have grown from 7 to 8 millimeters over the last 6 months. Those are the ones where we're being a lot more judicious about doing a biopsy right now. I would say the same thing about a liquid biopsy or versus a tissue biopsy. When you need that tissue biopsy, they get that. But if it is in a setting of acquired resistance, and you could go either way in this setting, I would be a lot less inclined to do a tissue biopsy where it isn't clearly necessary. And just like Stephen said about the scanning, we are not paralyzed in terms of our ability to get scans. when there's a reason for it, when you need to get that assessment. Certainly when patients are having clinical changes, it's just we're being more judicious about it when it was otherwise more of a ritual of doing it every 6 or 9 weeks, asking if we can go longer and still do perfectly well for our patients.
And the other thing is a lot of places, including our institution, have put elective procedures on hold for quite some time. So in Ohio, we did social distancing so early. We're actually doing pretty well, although we're still preparing for a surge of patients if it comes. But as of right now, I pick up a phone and call up the pulmonary group about, getting an EBUS, and I hang up the phone and turn around, and they're there with their spacesuits and already have the patient under anesthesia. I mean, it's actually the access has gotten better because of they've cleared out all the other stuff. So we can definitely get it, but it depends a lot. I mean, if you're in New York, all of those people are getting pulled to do critical care and not available for bronchoscopy. So it'll vary a lot from place to place.
I think the concern with bronchoscopy is it is an aerosolizing generating procedure, and so it puts a lot more people at risk. So there are some institutions that are requiring a COVID test before the bronchoscopy. Here we're still staging the mediastinum when we need to, but if you have a stage 4 patient, whereas before I might have sent them for a bronch, now I am relying much more on interventional radiology and CT guided procedures, which aren't aerosolizing.
Thank you. How are institutions handling new patient evaluations, particularly in the context of enrollment to clinical trials?
So I can take that one. I think all of us, and I know this is obviously Jack's area of expertise, have rapid fire increased our ability to work with telemedicine. So while new visits are certainly, I think, more challenging than follow-up visits to be done via telemedicine, there is certainly, a subset of patients who would be agreeable to be seen via a telemedicine video visit. And if there is a way to sort of minimize our exposure and do this via telemedicine, then we have been trying to do that. New patient visits, otherwise, where we feel that it is absolutely necessary to see the patient in person, or if there's a reason by which they cannot avail of telemedicine. This is certainly something we have seen in Baltimore, patients who don't have telephones, or there are disparities which limit their ability to take part in a telemedicine visit. We have certainly agreed to see them, taking into account the risks of exposure for both the provider and the patient. In terms of clinical trials, I think, as I mentioned before, many institutions, including our own, have unfortunately had to drastically curtail our clinical research portfolio and are only offering those clinical trials in which there really are no other options for patients aside from that clinical trial option. So I think this definitely affects the treatment options for all of our patients across the board, no matter at what stage or line of treatment they are presenting to us.
And I would agree that we are bringing telemedicine to bear for a subset of our patients, and for many, it's a valuable tool if they are looking for a second opinion and want to corroborate what their local docs have said. We can do that without them traveling a distance and having that exposure potential risk. And so we are just generally asking for any patient, whether it's a return visit or a new patient, whether that can be done effectively as a telemedicine visit. Jarushka brings up a very good point that it's not perfect for every patient, either because of their need to be assessed in the room or because there may be issues with them not having the equipment or the technical know-how or the internet access. It's something that we can't trivialize. And so that is a factor to consider, but it is a tool for many people. And like she mentioned as well, we are all needing to kind of prune our array of clinical trials, but offer the ones that really bubble to the top as most important. I would love to see, not just for COVID-19, but on a sustained basis, a careful look at what clinical trial work can be done potentially remotely in the future, because it often involves a lot of trips, a lot of blood draws, a lot of ritual, that if we could make it more feasible for people to get some of that close to home, because it's really the same blood draw that we would be doing, very often at the centers. I think that's something that it would be great if we can improve on and make a more efficient mechanism for clinical trials that brought people back to the tertiary care center as minimally as feasible and allowed them to get as much as they could closer to home.
Great. Next question is, the recent New England Journal of Medicine article by Agnelli published just 2 weeks ago on the Caravaggio study seemed to suggest that apixaban would be a non-inferior oral alternative for VTE treatment versus sub-Q dalteparin. Would this treatment perhaps be an oral alternative for lung cancer patients with VTE during the time of COVID-19 pandemic?
Yeah, I think the DOACs, the direct oral anticoagulants, are certainly great options for VTE in patients with cancer. We've had multiple trials, not just Caravaggio, but low molecular weight heparin is also something that can be administered at home. So I don't know that it really provides any additional advantage. I would not extend this to COVID positive patients without known VTE. Again, while there seems to be some propensity for venous thromboembolism, that's not the same as saying anticoagulating improves outcomes. We don't know that.
Agree.
I think as well, there are some potential interactions between certain oral anticoagulation and some treatments that have been tried for COVID-19. There are known interactions between some of these and the ritonavir and some of the HIV medications, antiviral medications that have been used for COVID, as well as hydroxychloroquine. So before any of these changes are made, I would look very carefully and make sure that there are no interactions that we may be potentially harming our patients by doing something that isn't standard.
How are you approaching patients with early stage lung cancer for curative resections with postponement of elective procedures?
So again, I think these are being discussed every week within our multidisciplinary tumor board. And I think in line with some of the discussions that we've had, I think these management decisions are very regional and will vary depending on resources, hospital capacity, as well as operating room time available. The ACS put out guidelines regarding tiers of surgery, where certain early stage lung cancers, especially those that have tumor size less than 2 centimeter or ground glass GGO or a less solid nodule, can perhaps wait, similar to a differentiated carcinoma. We are certainly engaging our surgeons early. They are engaging us early for the more advanced cases, for the stage 2s and the resectable stage 3s, to have these discussions. And I think the situation will be very different in New York versus Cleveland, as Nate pointed out. So I think, again, hospital resources have to be factored in these decisions.
Yeah, we can't be so dogmatic. If resources are limited, Astro and Estro released their guidelines, I think, yesterday, showing that for a stage 1, if you didn't have access to resection, 100% would recommend SBRT for an early stage. But right now, we're mitigating risk without compromising care. And so if someone has an early stage resectable cancer, we will take that person to surgery right now because we do have the resources to do it. And it may change as the surge comes.
But as Charu mentioned, I think we wouldn't want to paint with one brush that it's not like all resectable lung cancer is the same. There's a real spectrum of risk, and a node negative sub-centimeter or 2 centimeter nodule is not the same thing as node positive and larger disease. So I think we'd really want to factor that in and individualize, and of course include the issues about what our environment is where they would be getting treated.
And this was already mentioned, but just the importance of the multidisciplinary discussion. I mean, this week I actually was convinced to start neoadjuvant chemotherapy on a N1 biopsy proven N1 positive stage 2 patient, rather than taking them right to surgery, which would be our normal standard of care. And I'm not normally a neoadjuvant chemotherapy person, but in this setting, it seemed like the prudent thing to do.
All right, I'm going to try and get one more in on here. And this is something this has been discussed a little bit before, but how are the frequency of treatment schedules, particularly for IO therapies, being adjusted at various institutions?
Whatever we can get away with, we would, our inclination is to extend that interval. Jarushka mentioned already, if you can go to 4-week, I have a patient who's on the Pacific trial regimen, and I am trying to get that changed from 2 to 4. I would be very interested in going from 3 to 4 or even 6 weeks for pembrolizumab in many patients, but we do need to also acknowledge that we have to work within the confines of what's going to be reimbursed.
The FDA approval of Q4 weekly Atezo was helpful. The Q4 Durva that's used in Caspian is helpful. We certainly wish that the Q6 Pembro application had gone through. But in addition to using the sort of less frequent intervals, sometimes skipping a dose is okay depending on where you are in treatment as well. And so if the risk is particularly high, the half-lives, as we talked about, functionally is so long that skipping dose really isn't going to have much impact.
Yeah, I've had some people who are on their 10th month of durvalumab, and we've had a discussion and just decided that we're probably going to stop that and bring them back in a few months.
Yeah. Good.
All right, that appears to be all the time we have left now for questions. So again, a huge thank you to our faculty tonight, Drs. West, Dr. Pinnell, Dr. Liu, Dr. Agarwal, and Dr. Naidoo. Thank you so much for taking the time out of your very busy schedules and virtually sitting down with OncLive and talking about these very, very important topics with our audience tonight. And thank you also to our listeners, and I really hope you were able to gain some valuable insight into the clinical practice and how much it's obviously changing in oncology during the pandemic. Again, we are making these webcasts a regularly occurring series, so you will be able to listen back and watch us again shortly following the ending of this webinar. Our next one is scheduled for April 22nd at 8 p.m. And for next week's program, we will have another very special edition. Dr. Miriam Knoll, who's a radiation oncologist at John Theurer Cancer Center at Hackensack University Medical Center, will be with us, so we're very excited about that. And in closing, you can continue to visit onclive.com, sign up for our e-newsletters, or follow us on social media on Twitter, LinkedIn, and Facebook to get updates on when we'll be broadcasting more of these webinars. So for all of your oncology news, please visit onclive.com, where you will also find our COVID-19 Resource Center. So that concludes this evening's webcast. Thank you so much, everyone, and have a wonderful night.